talk about mobile phones for self-monitoring and self-management among people living with HIV. And I just have to introduce myself. My background's in medical and psychological anthropology initially, and then in public health. And I've been working in the sort of evidence-based HIV prevention world since 1994. And so I'm kind of very much coming from a tradition of face-to-face interaction and manual-based interventions. And here we're excited to be, and basically self-management for people living with HIV and now as a chronic illness with the advent of effective treatments. So I'm excited to see the opportunities that mobile technologies bring into this kind of work. And so this is really based on collaborations with computer scientists at UCLA that we started working with about 4 years ago. For some reason, the link is not popping up there, but we are building and they are building an open source mHealth platform for research and intervention that we had been calling And Wellness and is now called OHMAJ. And you can check it out at www.ohmaj.org and also at openhealth.org. And as I mentioned at the intro, it's really sort of motivated and guided by the billions of mobile phones across the billions of users on the planet. And the screenshots at the bottom of this slide show what's already happening in the marketplace with mobile health apps. UbiFit for physical activity, there's mood phones and various other kinds of mental health sort of support and treatment-based applications and so forth, moving out into the marketplace sort of ahead of science. And so we're just trying to basically create a platform that allows different folks to be able to design easily, just like these community health worker platforms, but focus more on the patient self-monitoring and self-management side, or client self-monitoring and self-management side. Now, the science behind what we've been developing is really coming from 3 related disciplines: the experience sampling method, ecological momentary assessment, and ambulatory assessment. So if any of you have read any of this literature, that's kind of what's guiding the science behind it. Ambulatory assessment comes from medicine in Europe. And in that research, what it really involves is daily self-reports or other kinds of monitoring of behaviors, of states, of symptoms. And in those studies, there's a reactivity to the assessments. And what that means is, in about half of the studies that have been conducted of these EMA-type studies, participants report decreasing the behaviors, the problem behaviors that are being reported on. Now, the basic researchers that do this work call that a nuisance because they want to see how symptoms and behaviors sort of relate over time. And as an interventionist, we see that as an opportunity. And so that might be called ecological momentary intervention. There's different kinds of data that can be generated from mobile phones. And I'm going to show some demos on the phone in just a minute, but just the overview. We can get self-report surveys. We can get brief open-ended reports and annotations. We can do digital, still images, video, audio, and also annotations. And everything can be time-stamped and, when appropriate, location-stamped if we have GPS-enabled phones. Also, there's unobtrusive and low-burden data that we can collect on smartphones and similar devices specifically. For example, location based on GPS, cell tower and Wi-Fi triangulation, which we can use to infer mobility and location, accelerometers that we can use to infer activity, not only movement and exercise, but also sleep and wake and activity and inactivity. We could also potentially mine call logs and SMS text message logs for research purposes. And also we can attach peripheral devices like biosensors, blood sugar, the microscopes, for example, by Bluetooth or even by wired. And one of the key things, some of the key issues that we have to struggle with when designing these types of applications are the sampling or triggering schemes. We can have participant initiated, so I'm the user and I choose when I want to complete data entry or a survey. I can have time-based prompts, so it's basically like an alarm that goes off and triggers me to complete some self-report or take a photo or whatever. Location-based prompts, which is also called geofencing, so based on the location that you enter or are in, you could get a prompt. And then there's other sensor data-based prompting that we can leverage, like the accelerometer, so when there's movement on the phone, Bluetooth and Wi-Fi signals, other peripheral devices, and these also can be randomized and linked to other data and kind of triangulated with these different kinds of prompts. And the last thing would be to consider would be the sampling frequency. And that means to anticipate the frequency of the experience that we want to sample. So if we're looking at things like in the moment, multiple times per day, or when we experience them and we want people to report, that would be called ecological momentary assessment. If we're looking at multiple times per day where we get kind of triggered surveys or questions, that might be called the near experience survey. And also we can do daily diary, once per day surveys, and we can do weekly or more short-term retrospective. And one of the key lessons we've learned so far is that we probably need to be adaptive in some way in these assessments, because for different people, for different individuals, the frequency of the experiences that they have will vary. And so if we kind of ask people too many questions on something that's not directly part of their daily experience that they're experiencing right now, they get kind of annoyed. And I have a kind of funny little anecdote about that I'll share with you in a minute. Now, we've just completed a study with 50 people living with HIV in Los Angeles who were mostly recruited from AIDS Project Los Angeles, and I know Jeff Bailey was here. If he's still here, thank you, Jeff, for your help with that. 2/3 of the people were assigned smartphones with daily surveys over 6 weeks, and 1/3 were randomly assigned to a web survey condition where they did web surveys every 2 weeks. Actually, everybody did web surveys every 2 weeks, and that was to kind of establish a comparison control group. Our goals for this pilot study were user experience, feasibility, validity, and reliability of data compared to retrospective self-reports, and also potential benefits, but it wasn't really an intervention study. We were really focusing just on self-monitoring, but we wanted to see if just self-monitoring alone might have some behavior changes. And I don't have data to present to you yet on that, but there's qualitative data from user experience interviews that I'm presenting on a poster on Thursday, so you want to come and check that out, we can talk about it more. What we measured was medication use, sexual behaviors, alcohol, tobacco, and other drug use one time per day, depression, anxiety, fatigue, and energy 4 times per day, and what we would call participatory assessments like stressful events and photo diaries whenever a participant wanted to do it. And it was sort of framed as like, we want to understand what's going on in your life, in your daily life, in a new way that you haven't been able to do in the traditional research projects that you participate in. So these were folks who are really experts at participating in research projects. I mean, they've participated in tons of research projects. So the idea was, you've all done the retrospective surveys that ask you about how many people you've had sex with over the last 3 months. What we want to know is, what can you and we learn from a kind of a mobile phone-based daily assessments. And we also had visualization on a website where participants' data could be visualized for them, and they might gain some insights from it. And the next phase that we'll be starting in a few months is the next round of piloting with methamphetamine using men who have sex with men in outpatient treatment settings. And for that phase, we're going to iterate and develop visualizations on the phone, goal setting, and sharing data with their counselors. So kind of bringing that data into the kind of provider-patient interaction is the next goal for this platform. So with that, I'm going to move to kind of demoing how these work on the phones. We used Android smartphones to start with, but this would eventually be ported to iPhone and other kinds of platforms. And there's another exciting development as well that could work on any phone, called Mobile Web Framework. It would work on any phone with a web interface. That's also being developed at UCLA. I have to get out of here now and get to my camera. Okay, so this is, there we go. Okay, so this is the phone with the app. Here's the And Wellness app. And these are the different surveys: the stressful event, the general feeling, medication, sexual encounters, and ATOD, and the photo diary. Now, to set up the study, we asked people to set triggers for when they would be most likely to be able to complete a survey. So for example, I can create a new time-triggered survey, and I can set the time to be, just for sake of ease, I'll set it to be 8:25 in the AM. And it will repeat every day, and if I wanted, I could set a time range that would give me kind of a randomized reminder between, let's say, a 1-hour time period. Now, we put these in the hands of the user, but these could also be researcher tools. So if you wanted your reminders to go off at random times during a 1 or 2 or 3 hour period to try to capture an experience, we could then click the randomization button. Okay, we could also add a trigger for locations. So the location trigger would be, and I can select the survey. So here I might say that I want my medication survey to go off when I'm at home, and I could set that home thing by either dropping it or by inputting an address onto, I can either drop it onto this map. For some reason the map isn't rendering just because I think the data connection is slow here. But in any case, I can also just put in an address here, and it would set the location trigger to be at my address. And actually most of the participants set their medication reminders to go off at their home in the mornings, because that actually turned out to be the place when they would take their medication. And what we learned from the user experience survey so far is that they were really using this as a medication adherence reminder system. And of course, we didn't instruct them to do that. That's just what people naturally did, given the power that this mobile app gave to them. So I can just go through a couple of the questionnaires. So 4 times a day, people were asked to complete questions on depression, feeling sad, blue, or depressed. And I could say, well, today, I wasn't really depressed. Skip next. Was I worried, tense, or anxious? I would say extremely, considering this presentation. Did I not get enough rest or sleep? I would say somewhat, considering I'm not at home and it's always hard to sleep traveling. And do I feel very helpful and full of energy? Somewhat. And were usual activities were hard to do? Not at all. Okay, now those were based on the CDC Health-Related Quality of Life survey. So I submit that survey, it's done. I could also give, let's say, a sexual encounter report. So how many sexual partners did I have since my last survey? So we trigger these every day. So people get a reminder to take the sexual behavior survey every day, but we anticipate that people won't be reporting every day. That said, some of the feedback we got was, I hate the daily reminders to do the sexual behavior survey because it's reminding me how much sex I'm not having. So that's where we'd like to get adaptive in some way. I don't know how we could do that, but we can get there. We also have a vision for the future. If people start to report that their sexual behaviors in certain locations and certain times, that they might get, there would be sort of algorithms that would do pattern detection, anticipate when people would be likely to engage in sexual behaviors or substance use, and would get automated triggers based on that. So let's say I said I had one sexual partner, and let's say that was, well, I'm going to say it was today. That's fine, but I'm going to say it was at 2:30 in the morning, okay, and it was a new partner, J, okay, next. Oh, I can check next. So I'm selecting TJ. TJ was a one-time or first-time partner, and TJ is transgender, and positive, I think, or guess, but I didn't actually really ask. I'm just guessing. And does this partner have any STIs? And I would say, no, I don't think so. And did you use a condom? And I would say, yes, this time. And what kind of sex we have? Anal and oral sex. And so I was the top. And did you use sex? And I would say no. So let's say I received the oral sex. And did I use condoms there? Certainly not. Okay, and was I intoxicated or high on alcohol or drugs? Yes. And I could write some notes about this, like it was hot. Okay. Okay, did you have any other sexual encounters since your last survey? I could go on and continue to repeat, but I'm going to just say no, and I can submit that. Alcohol, tobacco, and other drugs, I can select multiple drugs here. We list the main ones: alcohol, tobacco, marijuana, cocaine, methamphetamine. But let's just say it was alcohol, and let's say I had 5 drinks, and that began at, actually, let's say that began at 9:30 p.m. yesterday. Okay. And I can write a few notes about this, like, I was drunk, whatever, and that's the completion of the survey. So this kind of demonstrates where we got with version 1 of this platform. And version 2, I have what we have now are, which we'll be implementing in the next study with some other innovation. will be, gosh, I hope that you guys could actually, yeah, I think you saw that. Okay, so here's the OHMAJ app. So this is the kind of new updated version. And what I'm just going to show you on OHMAJ is the feedback page. So we have a new kind of jazzier user interface, but what I'm really excited about is the feedback. So this is taking the individual's data, and this is from a study on diet, stress, and exercise with moms. So it's not HIV related. We're actually running multiple pilots with different kinds of user groups, cancer survivors, with different kinds of behaviors, and so we can get we want to build a robust platform that's tailorable across a wide range of populations and user groups. But my favorite charts would be this one right here, because I think this is where this is similar to what we had on the web interface page, but not quite as pretty. And this is lining up 5 different reports: food quality, quantity, exercise, stress amount, and the time I spent for myself. Now, for the study with people living with HIV, this would be my mood, my stress, my substance use, my medication adherence. So what we would be looking at here is reflecting on my data, where am I seeing associations or correlations between, say, my stressful events, my depression, my medication use and adherence, and maybe my substance use and sexual risk behaviors. Then this one's a little harder to see, but basically what this is a goal. It's sort of a goal-setting support interface where the dark bar is where I am on the week so far, the dark bars, and the lighter bars are my average over the last week. So I can kind of see, am I improving on any of these behaviors over my prior week's reports? And these are across the different kinds of domains. So we can see from my food quality, I'm actually not doing as well as I did last week, but overall I'm doing pretty good. The dotted line in the middle is actually a baseline, which is an aggregate over the last 3 months. So that line right there. Here on my food quantity, we can see the dark bar is the week so far. So I'm doing better than I did last week, but I'm not doing as well as my overall baseline average over time. And there's some other things. I can look at my responses over time, and I can view a map of my responses. Now it's not rendering, but what's really cool is, oh, there's the map. It finally came up. Cool. So here's a report that was given on a midday, and I can see my responses at that location. So I could see that I was stressed and tired and irritable, that I felt like my stress was out of control, that I ate alone. I could see various basically things that I reported, and I can go back and view the map. So in terms of people living with HIV, we might see that there would be associations by geography with certain kinds of behaviors that I'm trying to set goals for and self-manage. So that's the basic interface and kind of where we want to go with this. And I'm happy to have taken less time, and I hope I did. And I can take a few questions before we move on to Kathy's presentation. Oh, thanks.
So my question is, once you move to the issue of having clients hold the phone,
yeah,
you could probably sell a cheap phone you can get at least one rocket crack for, and then, but if you have those fancy phones, you could get a lot more crack. And how do you make sure that people don't exchange their phones for goods?
Well,
Or have you just done pilot studies to date with people who are going to be reliable? And I don't know if other people have these issues. So I want to use mobile phones, but the feedback from focus groups is we'll sell them.
Well, it depends on how you do the incentive structure. So if it's a research study and they're getting money, then you can build the incentive structure based on returning the phone. Now, we did have, out of 50 people, about 5 lost or stolen phones out of the study, so that's about a 10% rate. So it's not foolproof, but it can happen. You can also do very, very similar things with very, very inexpensive phones, basically just using SMS and text messaging. Not as fancy, but you can still get some really great basic kind of survey response stuff and messaging going out to them. So that's another option too. We're designing for, say, 5 years down the road, like what kinds of phones are everybody going to have, at least in the United States, in that period of time. But there's lots you can do with much simpler devices, and I think that's actually where Kathy's talk comes in, and I want to get started with that. Or we could have one more question, but I want to get started with her before everybody runs.
Just a quick question.
Yeah.
Greg Kirk from Baltimore, also working with drug-using populations using EMA and other type methods. We actually do the incentive at the end of the study. We're only following people for 1 month, and we have a loss rate of one device every 280 days of observation. So if you do that incentive, even in drug-using populations, it does seem to work pretty well. We've only done relatively short studies, and I'm just wondering, what's the time frame that you've been looking at to follow individuals, and have you been adaptive in sort of reducing the burden over time? I get tired of an app after about a month. I'm just wondering if you have a sort of some framework for how long you can do this.
Yeah, and I think that's where the adaptive kind of surveying comes in. We also noticed that for the people that dropped out, which was not very high, we had a 90% follow-up at 4 weeks, 92%, and 80% follow-up to 6 weeks. So there was definitely a drop-off after that 1 month time you're talking about. And people just said, I got tired of it, or a life event came up, These were kind of pretty marginalized folks who are on disability, that's why they're oftentimes participating in research projects. But with that, there was still pretty good follow-up rates, and that's why I think we need to be adaptive and mix up the questions, build in more interaction, more of this goal-setting stuff, making the data more useful and appealing and useful for the individuals, linking it with a care provider, because a lot of people said, this would be great to share with my care provider, really make me feel like I'm more connected to them. That's kind of the next step that we're going to.